We're going to be talking with this lovely audience on high volume experience of flax, our learning. The team is absolutely Jabardast here. You know, it's better than any IPL team that you can have. Dr. Yeah, can you? Dr. Tityal is there, Dr. Ramamurthy is there. We have Dr. Tushya Om Prakash, Dr. Gaurav Luthra, and Dr. Rohan Mehra. So you can see that it's a power-packed team that we have managed to get. Patient selection in flax, the most important step. That is Dr. Tushya Om Prakash is going to be speaking to us. Which patients to select? According to me, anybody who can afford to do it should be doing it. There is no question, second doubt in my mind. But Tushya is going to tell us more on that. From the President, Dr. Tityal will have guide to opening the flax incision, pearls and pitfalls. I'll be talking on flax in posterior polar cataract, pearls and pitfalls, capsulorhexis in LRCS, advantages and challenges. Dr. Ramamurthy, you know, rhexis is the most important step in any cataract surgery. And addressing the conundrum, flax in black and brown cataract. Every which way a black or a brown cataract is the dangerous one. So using flax for astigmatism correction by Dr. Rohan Mehra. Now, most important, what is the purpose of the whole IC that we have? From theory, you learn a little bit. From practice, you learn a lot more. But maximum you learn over time from the mistakes which you made, from your theory and from what you have seen. And that is what is to be shared and discussed so that history repeats itself. If somebody has faced a complication, you will also face it sometime in life. All the speakers will be showing what were the problems that were with flax. Sounds simple, but there could be problems from which we have to learn. So learning from our mistakes and the expectations of giving a better result to the patient is the most important part of the whole thing. It's a comprehensive coverage which we have, and it's not a monologue as always. It's please stop in between and ask us. It's a dialogue. So it should be a free-floating thing, and feel free to ask any question anytime. That's the most important part. We begin with our first speaker, Dr. Tushya Om Prakash. Tushya, over to you. Thank you for being here. And it's always a pleasure to see all you winning all the academy sessions everywhere, ASCRS, the American Academy, and rest of the places. Always innovative and coming with something new.
Thank you so much, sir, for your kind words. And I would like to thank AIOS and Dr. Himanshu, Dr. Rohan, and Dr. Pooja for giving me this opportunity. So, as told by sir, I will be taking up patient selection in flax, the most important step. So for me, there are a couple of things which are important for the patient selection. First of all, that the pupil should be adequately dilated. Preoperatively, we always analyze this. So my cutoff is 4.5 millimeter. And specifically patients on IFI, pseudoexfoliation, diabetes mellitus, history of uveitis and trauma, we check, and I always start NSAIDs 1 or 2 days before, so as to prevent any intraoperative meiosis. And then the other thing which I check in the patients is proper positioning. Have to check whether the patient is obese or if he has neck issues. Then I usually avoid such patients because they have problem in positioning under the machine. Anatomical factors like deep socket, narrow palpebral apertures, loose conjunctiva, we have to see that we have to be careful, as these are the reasons for suction loss during the femtosecond procedure. Then of course uncooperative patient, anxious patients, Parkinsonism patients with tremors, and that's why I spend some time for good preoperative counseling so as to tell them, so as to check whether the patient is physically fit, good dilatation, and I explain them about the procedure so that they are prepared for the procedure. There are a couple of things where I don't do flax, like severe subluxations and small pupil. My cutoff is 4.5, but I've tried till 4.2 also, but I usually avoid below that. Then scarred corneas, as you can have misfired areas, then severe nystagmus, small palpebral apertures, severe conjunctivochalasis, of course small hyperopic eyes as there is difficulty in suction, and then when you have an uncooperative physically unfit patients. But of course, my procedure of choice of flax are all these conditions like white and hypermature cataracts. It gives you a very good opportunity of a fast capsulotomy, then weak zonule pseudo-exfoliation as there's a difficulty in doing rexes. Then you have traumatic cataracts. Dense and mature cataracts will be dealt later by Dr. Gaurav. Posterior polar will be dealt by Dr. Himanshu. And then, of course, cataracts with pre-existing PCS, especially patients who had previous anti-VEGF injection, as you get an advantage of an OCT in flax. And then small eyes where, of course, with very low ACD, you get difficulty in doing capsular rexes and phakomorphic glaucomas. So let's talk about how I'm going to discuss few complex cases in flax, like how flax has an advantage in white cataract because you have fast completion of capsulotomy to prevent initial injection of fluid into AC once capsule breakthrough occurs. So you can do it titrated within 1 second so that once the fluid comes out, before that the capsulotomy is completed. And then you have an advantage of a closed chamber. So this is a case of a hypermature Morgagnyan cataract where you can see the lens thickness is just 3.2, which is, we have a small nucleus in that. And what I do here is I titrate my settings in capsulotomy to make it 1.1 second. It is done by you can decrease the diameter. I usually decrease it to 4.5 here. I've kept it 4.7. And then you can increase the vertical spot spacing. Normally it is kept at 10. So you increase it till 13. So that's how you reduce your time. So you can see here it is 1.1 seconds. So I'll just go through the procedure, how it is done, and how you can see here while I was doing the OCT, the flax OCT, there was a problem in the detection of the lens anterior surface and there was fitting errors. So what you do is you just rescan it, just check, and you'll see that because it is out of the normal range, the size of the nucleus is very small, so it gives you these fitting errors. So you manually adjust them according to the anatomical surface. So I'm doing the anterior surface of the lens, so you can do it. It is very easy. So that's how you do the anterior surface, and then the posterior surface is also matched with the posterior. So I've kept a 750 micron posterior capsule safety margin also in this because of the small nucleus. So iris mapping is also done manually. So once it is done, you can see you can match all the anatomical surfaces very easily, and then I increase the vertical spot spacing for the capsulotomy so that to reduce the time to 1.1 seconds. And these are all my settings. I have increased the posterior capsule safety margin also, and then you press the button and you'll see here that it is all matched, and you can see that the capsular rexes is just for 1.1 second, and by the time the fluid comes out, the capsular rexes is completed. So that's the main aim, because once the fluid interferes in the laser, you can have uncut areas. So you see here, there's a milky fluid in the anterior chamber. So you have to shift it immediately, like in half an hour's time. So always remember to do capsular staining in these technique. I use a 30 gauge needle under air technique. So with few drops, you are able to stain the capsule, because you know that you have these uncut areas, and if you don't stain, you can end up into an anterior capsular tear. So you can see that 70% of the capsule is free floating. So for the rest of the area, you just do a normal capsular rexes in a circular guided way, and that's how you just complete it. So this was a hypermature Morgagnyan cataract. As you know, the nucleus size was small, so I was having a difficulty in holding the nucleus while doing chopping. So what I strategically do is, in these cases, is I take the equatorial support of the bag to immobilize the nucleus so that I can chop it easily. So you'll see here, what I do here is I immobilize the nucleus by taking the equatorial support of the bag and then doing a direct chop. So this makes it very easy to chop, as you know these pieces are very small. And you can also do an IOL scaffold before taking out the last piece, because in these cases you have vitreous syneresis, there is PC flutter, so you can do that also. So it becomes really easy and the case is completed. We published this nucleus management technique last year as well. So coming to fibrotic cataract, again you have an advantage of closed chamber. So advantage of doing capsulotomy in fibrotic cataract is that it cuts the capsule over the fibrotic bands. So you can increase the laser energy and incision depth can be increased because the anterior capsule thickness is more, and you can easily do capsulotomy in and a nuclear fragmentation in fibrotic cataract. So again, under air, always remember to do capsular staining because it's really important, as you can always end up into uncut areas because of the thick anterior capsule. So if you see here that the capsule is already 60% of it is already free floating, but because of the thick fibrotic band in one area, there was an uncut area. So the good thing in fibrotic cataract is that the capsular rhexis, it does not extend because of the fibrosis, and it doesn't let the capsular tear to extend till the equator. So you can gently do that. I used a Vanna's scissor to take out the last portion of the capsule, and then it was very easy to proceed. So similarly, at times, as we all know, that the capsular rhexis margin in flax have micro perforations. So at times when you make this was a anxious, uncooperative patient where I could only manage to do capsulotomy. So if you see in this case, we have to be very careful, but because at times you can have an anterior capsular tear in flax. So while I was doing cortical aspiration, I suddenly realized that there was an anterior capsular tear, but because I had flap motility sign in my armamentarium, so I kept continuing. I reduced my phaco parameters. I kept continuing with safe phacoemulsification technique because I was sure that the flap was everted and fluttering. So I kept continuing phacoemulsification. You can see while even injection of visco, you can see that the flap was everted and fluttering. So just to see the extension, it had extended till the equator. So my aim was to place the IOL in the bag as due to flap motility sign in my armamentarium, place the IOL in such a way that the haptics are perpendicular in the line of the tear, and it was a toric, so I had no option, so I had placed it and the case was completed. So another thing which we have started doing is, like, as we all know that in anti-VEGF injections there is a pre-existing PCR, so there was a pre-existing PCR in this. So we tell them to do flax because you can see the preoperative OCT, there was a PCR in this case. So what we do is we take the advantage of flax in two ways. One is by making a small rhexis so that I can do an optic capture, and then do a femto delineation. Femto delineation helps in providing me an epinucleus scaffold to the pre-existing PCR. So I'll show you how, and of course you have to follow low IOP phacoemulsification and slow motion phaco as described by Dr. Bob. So I have reduced my settings to 20 and 23 to 26 aspiration flow rate, and this is the case. So capsular rhexis was done, and slow motion phaco, low IOP phacoemulsification was continued. You can see the IOP parameters, this was 20. So the advantage is, basically my aim here is to have to do a low IOP phacoemulsification is to because there's a minimal pressure difference between the anterior segment and the posterior segment, so it prevents any pushing back of the nucleus. So you'll see these nuclear pieces will just float in the anterior chamber without being pushed. There is no undue deepening of the anterior chamber, no posterior bulging, and plus femto delineation. Because of femto delineation, you have an epinuclear sheet which provides you a shield to the posterior capsule. So you can see for cortical aspiration, I have retracted my sleeve of the phaco probe because you can differentiate the level of irrigation and aspiration simulating a bimanual IA. Once the epinuclear sheet is separated from all the ends, it is aspirated swiftly, dry aspiration of the remaining cortex is done, and 3-piece IOL is injected into the sulcus with an optic capture. and the case was completed and patient was 6 by 6. Always remember to inject triamcinolone to see the absence of vitreous. So I think that's 10 minutes. Okay, so just one or two slides on zonulopathy, because we all know that there's a difficulty in puncturing and tearing the anterior capsule. Then there is a shallow or a very deep AC, then lens is at times decentered, tilted. So there's always a chance of an anterior capsular tear in zonulopathy. So flax helps you out in these cases, but you have to remember that there's a greater risk of developing rips if you are using a capsular aiding device like a capsular hook, because of the presence of microperforations. You have to be very careful, as if you use a capsular aiding device, at times you can have an anterior capsular tear. Then micro movements of the lens often leads to irregularities in the capsular rim, and laser energy can be increased if there is a vitreous in AC. So in summary, flax is a very useful tool, as it helps you in a fast completion of capsulotomy, that is within 1 second, less nuclear manipulation, less energy dissipated, and it makes surgery safer and easier. Thank you so much.
Thank you, Dr. Tushar. That is excellent, great idea when not to do. Now, if you have a very wide cataract, to make it under 1 second is so difficult. Yeah. So do you make a rhexis smaller so that the first rhexis, as they say, otherwise with a manual, that will be as fast as possible before the fluid escapes? Yeah. Because even the Argentinian tear, I have seen in my own cases with a wide cataract, yeah, even in a flax, you can get one. Yeah. So how about doing a small rhexis? Would that take even lesser time?
So that's very good. I also mentioned, so when you have to reduce it within 1 second, you can do it in few ways. One is by increasing the vertical spot spacing, or by reducing the size of the rhexis. So yes, we can do it, and later on after IOL implantation, we can increase the size. That's a very good point, sir.
So the advantage of flax is actually the rhexis, and the disadvantage is also the rhexis, because the perforations can really create trouble, as he said, yeah, and sometimes that can extend. Yeah. How do you avoid that? How do you take care of that?
So basically, what we usually do is especially for hard cataracts, we make a little larger rhexis, so that while you are manipulating the nucleus, at times, if you have a small rhexis, it can lead to a rip out because of the manipulations inside the bag. So that is one point that we have to be careful, especially in harder cataracts. Otherwise, if you are making a good large rhexis, the chances of ripping out is less. It is more common in smaller rhexis and when you're manipulating in the bag.
Yeah, so every good thing comes with an added burden also, yes, but finally the surgeon is more important. And if you saw during pulling the fibrotic capsule, he was not doing a rhexis there. He was pulling it in the opposite direction. Yes. I think that would be the most important point takeaway. Thanks so much.
Thank you so much, sir. Thank you.
For such lovely tips. And of course, we have a president to give us the next talk on Guide to Opening the Flax Incision, Pearls and Pitfalls, Dr. Tityal.
Yeah, good morning, friends. Indeed, a pleasure to be amongst the top surgeons of this country, and looking for devices that are going to help us in making our surgery more predictable, more precise, and with a better outcome. Just what we are talking about in doing a capsulotomy in wide cataracts. I think one of the first studies we done in a wide cataract only. We compared the femtosecond laser-assisted capsulotomy versus the manual capsulorhexis, and subsequently the incidence of a capsule giving way in these cases. And we realized femtosecond was equally as strong as the manual surgeries. The only difference we found was the circulatory index was better with the femtosecond created capsulotomies. And the incidence of radial tear was almost similar in both the categories. Though we did have a little bit of incomplete capsulotomy in femtosecond, but those could be managed very easily also, that we all know. Let me take you through the another important part, which many people don't like to use them nowadays, with the femtosecond being so popular, more number of cases. So I would just take you through how to make a perfect incision, how to open them, and what are the various ways to handle these also. So if you look into femtosecond laser devices, it gives you various options. So one is your main incision side port, which is routinely required for all your cases. Along with that, you can also correct the corneal astigmatism. So you can do arcuate incisions, you can do a limbal relaxing incision also. Though I would say today LRIs are not in that practice for most of us, but sometimes we still do arcuate keratotomy in these patients also. So if you look at manual incisions, though they have been perfect, but we have various devices, blades, diamond knife. They always give you a variable corrective effect. The size may be variable, the depth may be variable. Sometimes you are too superficial, sometimes you're too deep, sometimes rapid entry, and sometimes very, very unpredictable incision can be there also. Therefore, there will be why not to use a femtosecond laser device for creating these incisions? So you require a good docking, then assessment of incision position and proper alignment are 2-3 important things also. So nowadays you have either a contact interface like you use for Lensex devices, or you have liquid interface like in other systems. I use Lensex, so I know how to do it in a proper manner. So good docking is critical, avoiding tilt, location has to be perfectly analyzed. Watch for other important issues like a very, very thick panels, pterygium, or deep set eyes can be a major challenge in sometimes. So this is what we plan here. This is a temporal main incision, then your 2 side ports. So if needed, you can do arcuate keratotomies, and that can be nicely planned here. So there can be a little bit of energy setup difference, though you can have the same energy and spot separation for a main and arcuate and side incision also. So that can be planned very nicely. You can plan always, depending on how you place your second instrumentation, that can be 90 or 240 degree along the central areas of incision, and that gives you your own orientation of doing these incisions also. So safe, effective, I can consider because it can definitely decrease the corneal cylinder in your patients. Excellent, precise one. In fact, we did compare the 2 incisions, one made with a femtosecond laser, other with the manual blades, disposable blades in these cases, looked for the configuration of incision in these cases and the DMD at the wound site in these cases. So we found there are 2 classical types of incision we create. One is a very smooth anterior or a proximal area of incision, and second is a ragged type. If you have a ragged incision creation, that has a much more chances of having a DMD at the area. You see this is a manual, you have a uniplanar incision most of the time, but if you have a femtosecond, so you can do a biplanar, triplanar incision making, which may be much more better in terms of apposition, much more in terms of better predictability in a post-op also. So these planning can be done by various formulas. You can use various nomograms to calculate these amount of arcuate keratotomy done in these patients. That will depend on the age of the patient, cylinder, with the rule, against the rule, or you can take into consider posterior corneal astigmatism also. So you can always go through the online calculator. But most importantly nowadays, people use modified Donald field nomogram for creating the arcuate incision also. So if you have an oblique astigmatism with the rule astigmatism, you can do a paired arcuate keratotomies. If you have against the rule, you can do a single arcuate keratotomy in these patients also. So this is one of indication. I think this is a patient where we'll be doing because this has a almost against the rule astigmatism, my arcuate keratotomy is coming here. That can be planned, and subsequently you can, when you create the fragmentation lens, then next will be incision. First arcuate, then main incision, then side port incision will come, which is effectively done in these cases also. LRIs are not really in practice, but sometimes you can do them when you have slightly larger incisions. It is always better to have toric IOLs as a replacement in these cases also. The challenge has been not only creation of the incision, its challenge has been to open them in a correct manner, easy manner, so that you don't disrupt the surface of the, because most of them are clear corneal incisions. So this can be done by various methods. If you have an OCT attachment, that gives a nice way to look into. So mainly we are looking for silver reflection from the edge by drying with the mirror cell response. You see here, this is the main incision, little bubble here. We have a triplanar incision there. This silver lining gives the idea that this is the incision area. So first you have to open vertically, then go tangentially, horizontally towards the anterior chamber. This can be opened very, very easily. So if it is a clear corneal, the things are simpler. But if you have little limbal incision, the things can be difficult in some cases also. So this is a new technique which I use nowadays regularly. Put a little bit of trypanol dye, which will enhance the incision area. It gives a very nice appearance of that area. Then you dry this area and you can easily go through this. So this is one of the perfect incision you can see here, right near clear corneal incision. Dry that after putting a trypanol dye, and you can simply open that with a spatula. First we'll do a little vertical opening here. Then just go horizontally, go inside, and you can see this will have a triplanar incision which has been opened here. The same thing for a side port also. And this incision, if you have a 2-incision side port, you can always manipulate your lenses, especially toric lenses. Manipulation, centration can be easier if you have a side port in both the side. You can manage with the right and left side ports to manage these cases also. And you can inject viscoelastic subsequently and take all the free-floating implant. Put the lens and the surgery is over in these cases also. So this is what I was talking about, a smooth slit section like this, or you have a ragged one. The chances of DMD depends on the type of incision you create. So if you look into your incision regularly under the microscope, you realize which incision might give you more problems. So this is one patient with significant astigmatism around 1 diopter. I say significant because these are patients who are undergoing monofocal lenses, not toric, and you can manage this. If you have a cylinder which is more than 1, then toric lenses would be preferred in all otherwise also. So this is the arcuate incision we have created. I'll take you towards the end of my surgery. So once we complete the surgery, I'll implant the IOL. So under the viscoelastic retention, then go there with the spatula vertically down and open this incision. Idea here is to have the chamber should be formed with a viscoelastic so that you can manipulate this. This is a smaller incision. If I have a slightly larger incision, I use this separator, which is open like we used to do RK those days, and we used to have a wound separator, which will give you the depth of incision also. The depth is quite deep here, and the depth also gives you idea how effective this will be in a posterior period also. The other advantage of arcuate keratotomy, you can do intrastromal arcuate incisions also, and that can be opened next day also. I missed that video, it is not there. This is the same patient I took in a slit lamp, and I could open the arcuate keratotomy next day. So you can have, next day you can titrate after your surgery. Don't open the incision on the table the day you're operating. Next day, see what is your amount of cylinder with the patient. Then you can still titrate opening of these incision also. That can be done. I take around 1 diopter as a cutoff for doing a arcuate keratotomy in a femtosecond laser cases. And that might help you in sometimes in cases where they don't opt for a toric lens. So you can customize your incision, size, shape, depth-wise. As I said, they have a better stability of wound during the surgery and a post-op period also. Chances of wound site DMD is less in these cases. Yes, there are difficult situations, deep set eye, uncooperative patients. Sometimes you have a large, arcus which may not give you a real good access to your laser being there, penetrating, and sometimes your incision may not be properly placed if you don't really look into the dimensions. One of the most important part when you are customizing your incision is to know white to white of your cases. That will determine how far back you have to shift your incision, and that will give you the perfect incision. Otherwise, you'll be always corneal, and that can be difficult. Sometimes it can be too posterior also. Thank you for your kind listening. I think if you understand these small things, your incision management will be better. But I would say this experience is based on a the LensX system where you have a contact interface. I think the planning of corneal incision are much better with these devices. Thank you again.
Thank you, sir. I think the point which conveyed is, I think up to 0.75 diopters and 1 diopters you can correct, and I can tell you almost 50 to 60% of patients undergoing surgery, you can use LRIs very easily.
Yes.
You can access the LRI even a year later. As he said, next day to titrate, you can use the LRIs. So thank you. That was very important. And especially when you're using premium lenses, one, it saves you the cost. Up to 1 diopters, you don't really have to use the toric lens. The femto really works out. And also you can correct astigmatism when you're using a multifocal. That is a bigger advantage to you. you can always go back and open up. The incisions are there for the rest of your life, the LRIs, so as much as you want it to work. Thank you so much. And again, a pleasure to have the president. First scientific session. I had the pleasure of sharing the dais with him. And congratulations to you, sir.
Thank you, Himanshu.
Thank you for your time.
I didn't realize this was my first assignment with you.
No, we had planned it that way, sir. We knew it, so.
Thank you, thank you.
Sir, but why don't you sit here now, sir? Ramu, come here, no, please. On the stage. Yes, please, of course. So, we had the pleasure of having two presidents, one ex-president, Dr. Ramamurthy, and the present one. Look at that. How lucky can we get? One second, Mike. Ron.
Very recently I had a very difficult experience in the sense that I also used to believe that just about a 0.75 to 1 diopter will get corrected. Actually, astigmatic keratotomy in laser arcuate keratotomy was planned for a patient at 22 degrees at 60 degrees axis. Length of 22 degrees at 60 degrees axis. One of my younger surgeons had unfortunately had docked, and then she made a 60-degree incision, arcuate pad arcuates at 22 degrees. And it's nearly now 4 months now. We have almost 3.5 diopters of astigmatism left over. And now actually I've ordered for a piggyback lens, and I'm going to, just going to be a custom-made piggyback lens, which I'm going to implant now. So even though we think that, I also believe that 0.75, 1 diopter is all that's possible. But this case, not even, I think it's almost 6 months, they have been difficult patient to handle. He received a trifocal lens. And now we are going to place a lens, and this correction which we achieved is quite stable over a period of time.
Yes.
It's of course anecdotal, but tells me that even such a large correction is possible. And second thing is that even most of our patients have against dural astigmatism, and in all these patients also I use a paired arcuates for the simple reason that they are at 8 millimeters, and I make all my incisions with knife. I mean, don't use the laser, and my incisions are anterior to that. So still I have the advantage of having an arcuate to deal with some amount of against dural astigmatism which all these patients have.
I think nice point highlighted here. Normally, the incision which are towards the apex of cornea, as closer to the apex, you will have a more effect of these arcuate incisions. If you go posterior, the effect of same arc length is less. More towards the apex, you will have more incisions. That's why we normally keep it at 8 millimeter zone to create these incisions. And second important thing is what Dr. Ramamurthy was highlighting. If you have your Varion, connected to the system, LensX, the entire thing gets transported into a LensX planning, and that also decreases the, the torsional effect coming in your docking. So you'll be always in the right place of your planning.
Dr. Himanshu, I wanted to ask you how is your experience with Catalyst system? I know you have Catalyst or
No, I have the
LensX?
LensX.
Okay.
I have the Alcon LensX.
Okay, so because at times we have that chances in opening the main incision, so we have stopped doing.
We have the Catalyst, LensX, and Zima. All of them make.
And Ramu's hands, sorry. The last part was Dr. Ramamurthy's hands.
Yeah, and I use that most often. My hands.
But don't you feel that at times that they don't open?
No,
and
they
you
don't
get that?
open. Sometimes you feel as if the epithelium is getting scratched.
Yeah.
And I find though, OCT pictures show that very nice triplanar incisions and all. Frankly, we hardly have any difficulty with incisions which are made with a diamond knife and very precise.
Okay.
If you have the diamond knife, the new blade which you have been using, rather than I've seen people using a blade, they do like this, then do like this, and that's going to create a ragged incision. And that is a major cause of incision-related problems.
The good thing which is coming up in Catalyst is like they have the limited market release, which is there with Dr. Mahipal and everybody. So they have integrated IL master with the Catalyst. So cyclotorsion compensation is done like how it is done with the Callisto. So
I think it's Cassini which is integrated, not the IL master.
IL master, sir. So limited market release they have done. So it's gonna come in the market.
Okay.
In Lensar, you could Cassini, and you can have Pentacam and Dial Master also, which is a newer portable device coming up.
Thanks very much for the input. I think everybody can share. Do you think, Ramu, that was a lens tilt actually? 3.5 diopters of astigmatism, which you saw post-op. This is a rare surprise, rare that I've seen the lens really tilted.
No. We made a 60-degree pad incision. Instead of making 22 degrees at 60 degrees, the way it was and she had opened up the incision also. So I thought it was just going to subside with time, so much effect will not be there. But it's just there.
So preoperatively, how much was the cylinder for that patient?
About a 0.75 or something.
Okay.
So required a pad 22 degrees at 60 degrees axis. Instead, some misunderstanding, she made a pad 60-degree incision at 22 degrees.
And then we normally tell, corneal incision, there will be regression happening.
Yeah, I was
But in
hoping
this
for
case,
the
he was
regression.
hoping, but it didn't happen.
Very interesting, very interesting. It's just the corneal fibers which can misbehave the way they are put. What it shows is, even in LRI, you wonder how will it function. It may scar. But it's just the integrity of the fibers which are affected. I think great. I'll be talking on posterior polar cataract. I think one of the biggest worry that we have is how to, whatever we do, a brown-black cataract, a posterior polar cataract is always going to give us some creeps in life that we anticipate. And more important is if you know from the beginning whether the posterior capsule is intact or not, it will help you tremendously. So looking forward, it's one of the safest way today that we can have. Which are the cases? I mean, we all know all these cases, bilateral. They generally present in the third, fourth decade, increase in size, strong adherence. But grading, light scattering, increased glare, when to do it. And most often than not, these patients come when they are 40, 45, that they want to do it. The career is still at the very precarious stage, and they have problems driving. Now, they have been carrying on their life, everything has been going smooth, and life has been going quite well. But when they start figuring out that going out in the sun, doing routine life, so what you really have to be careful here is the biggest problem that we have with the posterior polar. It can dip in and the posterior polar can give way. So long operative time, possibility of a nucleus drop, second posterior segment surgery. So I always tell my patients that this might be done in 2 stages. We'll try and do it in 1 stage, but this surgery might need a 2nd stage surgery. You have to prepare them from the beginning, and that's the most important part. So pre-existing amblyopia could also be there, and they are not even aware of it. So what are the ways out that we can have? Getting to do a good rhexis and a cylindrical pattern by which you can excavate the nucleus would make life a little more easier. Now look at that on the right side, your OCT is showing you that the posterior capsule is intact. You have the nucleus fragments done, you have a cylindrical kind of multiple cylinders which are made after the capsulotomy. You can plan your capsulotomy thinking that in case the posterior capsule ruptures and you have to put the lens, a 3-piece, in the ciliary sulcus, that also you will be able to manage provided your rhexis is intact. So that is important. Now look at this case. On the right side, if you see, the OCT shows that the posterior capsule is given way. So here I'm quite aware that I'm going to be in trouble. I have to plan my surgery, quite important, and I have to plan my cylinders that way. I have to reduce the pressure. I have to see every which way by which I keep the anterior hyaloid phase intact. And even while removing the epinucleus area and the posterior. So here, automatically what I can do is, I've done my rhexis. I know that I made it just the shape so that I can put in a lens fairly simple. And you made those cylinders which are there. You got them excavated. You can remove them later. You got your LRIs also done, like Dr. Tityal just mentioned, those LRIs which are there, and your primary incision and the secondary incision. So this, hopefully your planning stage is done well, and you can manage to do it later. So what you do is while operating, after this, do not hydro-delineate, no hydro. So visco is the one which has to be done even after nucleotomy. Any time which you are doing is visco dissection should be done. You don't have to do anything else, but you have to be careful that once you are getting in, you opened up your Rexis, you done your LRIs, you are doing visco. There is no place for any kind of BSS or saline or ringer lactate being done. Do not move the nucleus too much. Don't mess around. Don't see that the whole epinucleus area is free floating and it's away from the capsule. Just keep dissecting. Make it user friendly. It wants to come out. So gradually, gently, I have changed my position of sitting also to see that I go underneath the anterior capsule, put in some viscoelastic. This was more recalcitrant phase, by which that's why I'm showing it more at various cases and various angles that I've tried to remove the epinucleus. You have to be careful here. Again, I'm not rotating. You don't want to rotate. You don't really know what is going to be happening there. So you are trying to see that you get the epinucleus and the cortex out of the edge at least. I wish I could be on the opposite side, actually, in this case. And I could fairly easily remove the epinucleus. Look at that. Have patience. It wants to come out. And you got your things there. You look at that, you almost feel that you have had a rupture in the posterior capsule. But it's not, it is your posterior polar which has come off. So fair enough, this was a case where I could do, but more interesting is the case when, you have a posterior polar which has already perforated, like I showed you this case, case which posterior pole has been perforated, and you have to be careful, pretty careful to see that you don't mess around too much. You got your incisions going, you plan it that way. As much as possible, visco dissection. Try and see that you don't manipulate too much. Your pressures have to be under control. You have to see that the lower lip is being pressed anytime I'm pushing in fluid. I'm removing each and every cylinder. You can see that. I'm removing it in bits and pieces. It wants to come out fairly easily. There you have the posterior polar cataract with the epinucleus. You just nudge it. Don't mess around too much. Don't pull too much. You can be as liberal with your go slow. I know that back of my eye, I can see that there is going to be a rupture somewhere. And before I come out, I'm always filling the chamber to see that I remove it. Here, I was not sure where it will be, but look at what's happening here. When I'm removing the cortex, and since there is viscoelastic, even your aspiration is not going to work that easily because you're going to have the viscoelastic in your aspiration. Now look at that. I can see there that there is the posterior capsule has given way somewhere. So I'm going ahead with low fluidics, trying to remove my cortex. The anterior capsular axis is still very consistent. There is no vitreous phase which is come off. The anterior hyaloid is still intact. My pressures are low. I still have to be very patient, remove everything gently, cajole it out. And it's very respectful. If you respect tissues, the human tissues, they respect. Now look at that. Quietly the posterior capsule went down. There is no vitreous. It's a bimanual that I'm doing, so I have to change my hands. Here it was dry aspiration that I did. I did not have more fluidics getting in. I'm trying to do dry aspiration, which is again not very difficult. Loosen the cortex so that it becomes a little easier, because even if I have to put in a lens right now, it's not difficult later to remove this capsule, the cortex. So I'm loosening up the cortex as much as I can, gently and slowly. I had planned a multifocal for this patient, and the patient wanted a Vivity lens. So now that I've got on low fluidics, seeing that it's intact, there is no vitreous, I can still put in the lens in the bag. And well, that helps me. I don't really have to worry about anything else. So with your planning and anticipation and expectation, you could be fairly comfortable even if you know that the posterior capsule has given way, and you can manage it. These are various other cases. I don't want to waste your time. So point to be given is that the journey begins in planning at every simple step right from the beginning. The anticipation is most important. What to do, what not to do. A good rexis, a good amount of patience, going slowly, don't be in a hurry. And gradually as you are going, and you think you cannot, but well, if you have planned and you go slowly, take your time, see your side ports are there, you see the pressures are okay. It's a question of time before, you really get into your destination. And well, you just make it. It's just that your confidence has to be there. Do all possible things to reach where you want to reach. And you anticipate. This is a very interesting thing which I learned, how it is. You anticipate at every stage what can go wrong. These are things which can go wrong. That's the most important part at every stage. Where will you anticipate problems is what is going to help you in future. So if you anticipate, you can make the car that way. You anticipate, you know that what is going to be happening. Thank you very much for your time and patience. Posterior polar to be managed manually and to be managed with your femtosecond. Thank you so much for the time. Any
Those
questions?
were some great teaching pearls, sir. Sir, with the tremendous advantage of having OCT in femto and with sir's classification, and when we can diagnose that it is a pre-existing, as Dr. Himanshu sir also told, so we can also increase the posterior capsule safety margin also, so as to prevent any stress on the pre-existing defect. And plus, we can also reduce the diameter of the nuclear emulsification to prevent any air entrapment going behind. So these are a couple of things, and we can, of course, sir, so what is your preferred rexis size in femto for a pre-existing PPC?
I normally do around 4.8, 4.9.
Okay, so that you can plan on optic capture later.
If needed. That's a good size because there will be little expansion after we take out the nucleus, so it may become 5. But classically, it has to be around 4.5 to 4.9. You don't make it too big.
Okay.
Otherwise, you may have a difficulty in capturing. But yes, what Tushar is saying, it is always better to have a cushion effect in these cases and make a endonucleus and cushion separate.
Yes,
so things become simpler.
Yes.
But the most famous thing that Rohit also talks about and everybody wants to understand is managing the pressure. It should not be more, it should not be less.
Yes,
Pressing the posterior lip, seeing that you don't increase. Even we've seen Dr. Abhay Wasada's classical case, wherein the whole case was over. Side port when he's pushing in the fluid, and there goes the posterior capsule. The posterior capsule has a mind of its own in these cases, and it can give way at any given point of time. You have to be very careful, very, very careful at any stage. Just see the fluidics are low, go patiently, the cataract is not bad to deal with. I think each and every step makes sense. And we have our past president, Dr. Ramamurthy here, capsulorhexis in laser refractive cataract surgery, advantages and challenges. He had the largest experience, I think, with all kinds of machines. Thank you, Dr. Ramamurthy, for being there.
Thank you so much for having me here. It's indeed a pleasure and honor. Capsulorhexis in an LRCS, I'm just going to take you through right from my initial experience to what we are doing today. I think capsulorhexis is the most important advantage that the LRCS platform offers. And this is a docking that is taking place. You have seen this. This is the normal way the and I usually make a 5 millimeter rexis. When I'm doing manually, I aim at a 5.5 millimeters. But here it's 5 millimeters because invariably the rexis tends to retract a little bit and it's a little larger. So when I initially started out with 5.5 millimeters, I used to find it a little difficult to get a good overlap on the 6 millimeter optic lens. So now I've come down to 5 and stick on to it. And I think that effectively gives me 5.5. When the capsulorhexis is completely loosened up, usually you can go up with a down-up manner, go through the central incision, use a utrata forceps, and then pick up the rexis and it works well. Or you can go through the side port incision and using a 26 gauge needle and gather it up. And usually this is the situation that you see 3 months later, where there's a very regular nice overlap of a 6 millimeter optic lens, allowing whether it's a monofocal, premium, toric lens to function in a most optimal manner. I think that's the greatest advantage that the LRCS offers. What are the some iterations or changes that we sometimes encounter? This is actually a fibrous capsule over here. And as you can see here, though the LRCS platform has created a nice template on the capsule, it's not really freed. So in this case, if I go in with a utrata forceps and just to pull it up, there will be invariably a rexis runoff because there are areas of additions. So you have to be cognizant of this and then go in with a 26 gauge needle. You do exactly the same maneuvers as you would for creating a capsular excess. So as to, but the laser has created a nice template for you. And in a methodical manner, you just break down the additions and making sure that you do not use excessive force, and then you are able to end up with a reasonably good rexis and continue with the rest of the phacoemulsification procedure. So you have to be aware of the fact that not that just because you have this machine, it does not mean that it's going to be a free-floating rexis in every case, and you might have to do this. The earlier case was obviously a case with a fibrous capsule, but even in a run-of-the-mill early cataract case like this, whenever you see a situation like this, as you can see here, bubbles of air, places where the rexis is not freed up, then you have to recognize this. Don't mechanically go in and pull on the rexis, but recognize when the additions are still existent. And in these situations, it's always a good idea to go in with a 26 gauge needle and gather up the rexis in the center. These are areas where maybe because there's improper docking, even though there's a contour guided capsulotomy, which is supposed to compensate for that, sometimes you can end up with situations like this. So you have to free up those additions to not to have an issue. When you have a grid pattern underlying, this is on a different platform, this is on the Catalyst platform, then it becomes a little more difficult to recognize the rexis margin, because sometimes the grid pattern hides it. You can see it over here. This is an area where the rexis is not complete. So I've recognized that, and so I have to take steps so that I do not pull over there. So essentially my movement, once I hold the rexis with the capsular rexis forceps, is to create, just go around that area where the rexis is uncut, and that will show up even more obviously once the intraocular lens is implanted. You can see this slight rounding off over here, because there the rexis was not created by the laser but my surgical instrument. So you have to recognize these things. Do not assume that every case there will not be any tags or it will be a loose rexis. Even if it's a straightforward simple case, you have to have a good look and recognize that. One of the greatest advantages of applications of Elastius platform, I think, is to create a reliable capsular rexis in an intumescent cataract. As you can see, the fluid clefts and the lens is bulging forward. But as you can see, I stained these capsules just to see where it is, and quite often you find that it's a free-floating capsule and it's floating over here, completely separate. In a case like this, once you achieve this, half the case is done. So you go ahead and complete the surgery and implant the lens of your choice, what you had planned. So this is the situation most often, and I do believe that in an intumescent cataract with a very high intralenticular pressure, is definitely a great advantage to have an Elastius. But at the same time, this is not always the case. You can see an intumescent there. This is a platform which creates a rexis in just 1 second, but even that gush of fluid that occurs, I did not recognize that something is going wrong, but only when I stained with the trypan blue, you can see that the capsule is disrupted. In spite of using an Elastius platform, it's simply because the gush of fluid itself sometimes makes the rexis to rupture. It's a fairly irregular, but you have a rexis margin over here, you have some flaps here. Since the patient had already received, this happened some time back, I think then we are using the Symphony lenses quite often. The other eye had already received Symphony, and since I could position it in the capsular bag, I go ahead and implant the lens within the confines of the capsular bag, and the patient did reasonably well. So you have to be aware of the fact that in these intumescent cataracts, sometimes you can get into a problem like this. What about a fibrous capsule? Here again, getting a nice, as you can see, it's a shrunken fibrous lens over here, and the capsule itself is a little fibro. You can see the fibrotic patch over here, and because of this, if you have the Elastius platform, then I think it went too quickly. Then it creates a nice capsular rexis, and you can subsequently use a 26 gauge needle to complete the rexis. In a more advanced situation like this, where you have a fibrotic patch, I have used a Elastius platform, but the laser has not done anything to this. This is right in the area of the incision. I am trying to see whether just by using a 26 gauge needle, I can complete the rexes, but this does not work. In this situation, I should not go in with a 26 with a utrata forceps and pull on it, because that will invariably cause a rexis runoff. So what I do is to go in with a scissors, preferably a micro rexis scissors, and here since it was well accessible right through the central incision, I go in through that and cut the area of adhesion. So what really a $500,000 machine could not do, it's actually a combination of technique and technology. You have to understand where to use what. Basically a simple scissors comes in handy. But having said that, the fact that the laser had already created a nice template, round template, allows me to create a rexis like that, evacuate the lens, and this is the picture a week later. You can see the fibrotic patch still there in the periphery, but centrally a clear area and a 3-piece lens which has been implanted. What about a subluxated lens like this? This patient had a trauma at the age of 10, presented to at age of 30, and these are the only zonular fibers over here in this area. So basically, one of the greatest advantages here is that you are able to shift the rexis. It's a 5mm rexis that I am aiming at, but I know the final position of the lens is going to be different from where it is. So I'm shifting the lens a little downward and then subsequently going with the rexis. And it is also, any tilt of the lens is also taken care of by the contour guided capsulotomy, and this is what you see under the operating microscope. This is the rexis that has been created. This is a partially shrunk lens, but still quite a stable lens. It has remained this way for 20 years of the lifetime of the patient. And I do not use a utrata forceps in these cases, but gather up the rexis just by picking it up with using a 26 gauge needle and gather it up in the center, then subsequently remove it. And now I am doing a hydrodissection, because adequate hydrodissection is necessary. And all you need is a soft cataract, obviously, so all you need is a simple phacoaspiration. Then I will introduce an endocapsular ring. Because it was a traumatic cataract, we do not need a Ahmed segment or a CTR, but a Sionis ring. But I am putting an endocapsular ring. Subsequently, the intraocular lens, which was initially decided, goes in. As you can see, the major advantage I derived in this case was that I could position the rexis exactly where I want, got a 5mm rexis, and once I positioned the lens, it was worked better. This is another case of more significant subluxation of the lens, and here basically the offsets are getting a little confused, and I have to position them exactly to correspond with the anterior capsule as well as the posterior capsule. And once I do that and then fire the laser, then it works much better. And basically here I had to reduce the size of the rexis also to 4mm, because that was all here. You can see the rexis size is 4mm, because that was all the size of the lens that was exposed in this case. So I complete the rexis, and then you can see the way it is. Initially we are concerned about the strength of these rexis that's created, but I have found that none of these rexis, once properly created, gives way, whether you have to introduce an endocapsular ring segment, or whether you have to use capsular hooks or Ahmed segment, or you have to manipulate the lenses. And these capsular bags remain quite stable. Endocapsular ring has been introduced, and subsequently we put in an intraocular lens. What about the post-RK situation? As you can see, you have these RK incisions, and sometimes you get tags exactly corresponding to that, because in those areas laser has not passed through. So here again, because the grid pattern, I am not able to visualize the rexis, but then I gather up the rexis in the center. A week later, I did the second eye, because the uneventful way in which the first eye went, I went ahead and used a capsular rexis forceps to just pick up the rexis, and exactly corresponding to this incision over here, the laser has not acted, and you can see a rexis run off here. Actually, I recognize this only after removing the lens. So whenever you have any scars on the cornea, maybe it's a good idea to go ahead and gather the rexis in the center. And I think I'm coming to the last of my videos. In a post-ICL situation also, you can create a Rexis, sometimes in a post-ICCL situation, the anterior capsule is fibrosed, and creating a Rexis is a bit of a challenge. And you can, the only thing you have to again make sure that the proper recognition of the anterior capsule is done, because sometimes the laser confuses the borders of the ICL with the capsule. Once done, then you have to remove the lens, and then subsequently, again, it's not a free-floating Rexis because the laser has to pass through the lens. Bala from Australia has shown bisection of the entire intraocular lens, a hydrophobic intraocular lens, using the LRCS platform. This is the energy levels which can be generated with this platform, but obviously I have not used that so far, but then maybe that's another application for using the laser, if in case you have to expand the lens. And last of my videos where there is a Rexis discontinuity, this was actually a gynecologist who got operated on the second eye. I did not even recognize that something was wrong. Everything seemed to be under control. I picked up the capsule, and that's a grid pattern that has been seen. Only when the nucleus started coming out, I realized there was a lot of muck in the vitreous cavity. And here, exactly in this region, there is a Rexis runoff, and it has created a sort of a dialysis over here of the capsular dialysis, and that's the reason that some of the cortical matter slipped in. Maybe this is a good situation for going ahead and doing a pars plana vitrectomy, but I was more comfortable with a anterior vitrectomy. I go through the side port, and essentially, as you can see over here, there is still significant amount of posterior capsular support that is available. So my idea was to implant the trifocal lens, which was already received in the other eye by this patient a week back, and that's the anterior vitrectomy being done. And you can see a complete clearing of the anterior vitreous. I also checked with the transfluminal state to make sure it's completely bereft of any vitreous. And then I had slightly enlarged the incision because I didn't want to do a wound-assisted implantation. You can see the angulated way in which I am implanting the lens so that the haptics of the lens doesn't go into the area where the capsule is deficient. I was able to reasonably center this lens, and that is the end of the case. So capsular Rexis definitely is the greatest application as far as LRCS platform is concerned, but it is not without its challenges and complications. Once you handle them properly, invariably you get good results. Thank you so much.
Thank you, Dr. Ramamurthy. Excellent. All possible cases. RK, multiple cases that we see. Anywhere there is a mild opacity, you can increase the amount of energy going in, and that might help you to make your Rexis. Sir, about ICL being there, and your Rexis is complete, but you remove the ICL, or if it's an incomplete Rexis because the energy could not get through, you remove the ICL, in the bargain you can tear the anterior capsule. How do you prevent that in certain cases? Do you put in viscoelastic between the two?
Yeah, usually, I've done just about 4 or 5 cases of ICL and, laser, using the laser. Usually, once you understand that you have to exactly coincide the offsets on the anterior surface of the capsule, then usually you don't get a free-floating Rexis, but you get a round Rexis as you got here. And I always stain these capsules before introducing a viscoelastic, because there's usually anterior fibrotic patch. And then after removing, I have not had a problem with the Rexis runoff in these situations.
Yeah. Thank you so much. In the interest of time, we'll take questions a little later. We have our next speaker, Dr. Rohan Mehra, using flax for astigmatism correction.
Very good morning to everyone. Thank you so much, Dr. Himanshu, for including me in this course. So the first question when it comes to treating astigmatism is actually to treat it or not to treat it. Because we know that in a few cases, in a few situations, astigmatism can actually be used to our own advantage when it comes to post-operative outcomes. Size and location is the most important factor. We know that with age, against the rule, astigmatism keeps increasing. So we need to take that into consideration when we look at long-term results of our surgery. So 3 basic ways in which we can correct astigmatism: toric, LRIs, and arcuates. We know that flax has improved refractive cataract surgery outcomes over time. There are different flax platforms that are present: the Lensex, Catalyst, Lensar, and the Zemer. All of these have the inbuilt softwares in which we can use these softwares to take care of astigmatism in different modalities. So the image guiding assistance, as we know, there are the corneal incisions. I've marked them out for you so that it becomes much easier for us to see. Then you have the nuclear fragmentation, the capsular rhexis, the arcuate incisions are the ones there. So image guiding surgical planning with 3D visualization is of course an advantage. Real-time corneal thickness we get in this. We know the exact percentage depth that we have to go to. The length and position of the incision, 3D visualization of incision placement, predictable incisions, the width, tunnel length, titrable incisions, adjustable during the surgery procedure, and as Dr. Tityal had mentioned in his talk, adjustable post-operatively at the slit lamp also. So you can, we say that, you know, life gives you one chance, cataract surgery gives you one chance, but here actually you can take another chance later on as well. So this is basic planning on the LensX platform. Once you have chosen, you have all these parameters to choose from, and every single particular patient, you can go ahead and you can choose what your incision location is going to be, what your depth is going to be, what is the exact size you're going for. And there are various nomograms in which you can actually take care of it. So these are the most used ones, the Donenfield's monogram and the Solomon's laser arcuate monograms. These have been modified now, and there is work in progress for further modifications of these nomograms, which are used and can be used for astigmatism correction in flax. Then you have the Weinstock Panchal, that's also a limber relaxing incision nomogram that is followed. So here is a case, this is actually a posterior polar cataract, and in this case as well, you can see there are arcuates that are going to be made on the side after the planning is done initially, and you see you leave out a decent amount at the back because it is a posterior polar cataract. Then once the laser is fired, you will be able to see that even in these cases, predictably, one can go ahead and make arcuates and make sure that the patient gets the perfect vision that one desires to give to the patient. You see there. Now, sealing these arcuates at the end also, this becomes a challenge, like how much of fluid is to be put, how much of pressure is to be put, all these factors, and how well this gets sealed. Because we are used to sealing the incisions that are limbal, that are right at the limbus. This is something different. This is on the cornea. So sealing them, there is a slight amount of learning curve in this. So here you see, this is a beautiful video of a 3D. You see from the outside how you can actually open up that incision beautifully in the eye, and it is guided, it is neat, it is clean, and it gives us the desired result that we want. And these are the post-operative outcomes you can see in the image in the top right. There is a marking for the toric also, if you see, but there are those big arcuate incisions. So in our experience, as sir said, that up to 1 diopter, actually you can avoid a toric if you do use these machines that are there in our armamentarium, and they will take care of the astigmatism that is there for the patient. Of course, we have to consider with the rule and against the rule. So these are the vector analysis of refractive and keratometric changes that have been there. So you see the mean, the minimum and the maximum. And in all these cases, you can see that up to 1.21, 1.20, 1.2, 1.16. So consistently, this is the value that we are getting that can easily be corrected without a toric by using flax. So in the end, I would say that we need to evolve. Everything has to evolve or it perishes, and it is evolving with the ever-changing nomograms that are coming in. Thank you.
Thank you, Rohan. What is the largest amount of astigmatism that you have done, and have you ever done it after a couple of months again?
No, sir, not after a couple of months, but yes, about 15 days post, and it was about 1.5 diopters.
So it definitely has a place in time. LRIs were not very great with a diamond knife. We have done that in the past, all the various nomograms. But with the various machines that we have now, the Callisto, the Varion, makes life a lot more easier to plan in majority of cases. Again, in the interest of time, thanks for sharing your views on astigmatism. We have our next speaker, Dr. Gaurav Luthra. Thanks, Dr. Gaurav, for being there after such a busy schedule. He's going to talk about some of the worst cases of brown cataract, black cataracts, white cataracts, and on a femto platform. How good is it? How bad is it? Over to you, Gaurav. Thanks so much.
Thanks a lot, Dr. Himanshu. Good morning, everyone. And I'm sure almost everything is covered. I'll try to show you one or two cases, and we are very short on time, so I'll just stick to some hard brown cataracts. I think femtosecond laser has become an amazing tool. I like to use it for all the hard brown cataracts, and unlike the intumescent and the white cataracts where the OCT will not penetrate and check out the posterior capsule, and also unlike the very opaque kind of cataracts, but in the brown cataracts and the black cataracts, usually the OCT as well as the laser will penetrate and give you good cleavage planes. It also gives you a good size predictable rhexis. Usually these hard brown cataracts will have some fibrotic changes in the capsule as well, so it becomes quite useful. So this is where we are planning the laser delivery, and the planning also can be a little different from your usual femtosecond lasers. So I have switched from the 6-quadrant crack to the 8-quadrant crack. And let me just take you back and show you what all you could do. So in between, for a few years, we were doing these octants and this, along with that, getting these small cuboids. But this used to really use a lot of energy and could be sometimes endothelial unfriendly. And also it would, sometimes leave behind these small cuboids. So if you look over here, you could actually do a 4-quadrant crack and then have small, kind of a grid kind of a pattern, but we no longer like to do that. But yes, if you have a very hard cataract, a 6 or 8 quadrants done correctly with the correct energies will do well. So here I've switched to that, and then I'm changing the spot separations and the, to make sure that I'm getting a better cut and the energy as well. I've also enlarged my rhexis size to about 5.2, and then I'm going to just check if the LRI is also going to correct, just like Rohan was talking about. There's about 0.75 astigmatism, which I'm correcting with this single LRI. And then firing the laser. So you can go for a slightly bigger rhexis size, and you can, in these very hard cataracts where there's going to be lateral separation and you want a bigger rhexis size, otherwise normally I would do a 5 millimeters, but here I chose to do a 5.2. And once you have that in place, this is the cataract that we were operating. So these cleavage planes will be pretty good. Your rhexis will be quite, unlike what many people, would like to think that these rhexis are not very strong. They are very strong, and I'm yet to see patients, where I've lost the rhexis in femto because I was doing some maneuvers for the nucleus. So they are equally as comfortable as a manual rhexis. So once your capsule is out, then you have to deal with these, some of these really hard brown cataracts. And frankly, these cleavage planes work quite well because you can embed and then crack along these planes. And the phaco energy used is much less, and your endothelium protection is much better. So you will have a much, much quieter, cleaner post-op clear cornea. So had it not been for the cost of the femtosecond laser and the running cost and all that goes with it, this would be a great tool, in most clinics, but the prohibitive cost and everything that goes with it, as I said, the CMCs and the AMCs. So you can see that separating them becomes so much easier. I'm not having to apply that much force. Even cracking the posterior plate becomes easy because there's very little left at the posterior plate to crack. And lateral separation is much, much easier because you already have the cleavage planes. Of course, I mean, if somebody had to say whether you can do these hard cataracts without the femtosecond laser, you can, but if there's a better way to do it, then why not? So I'm sure many surgeons would switch to an SICS. If I can do a femto-assisted surgery, I would rather do that. I'm more comfortable with a closed chamber fluidics. Of course, SICS would be a great technique as well when there's no access to maybe a high quality phaco machine or to a laser assisted surgery. So you can see that once it becomes almost like a routine case because your cracks are all there. And of course, you could use the softening if you would like to use it. Some surgeons like to use the softening feature. I don't, because it tends to sometimes leave these very small nucleus fragments somewhere in the bag or in the sulcus, and they will cause persistent inflammation. So I stopped using that, the grid pattern, which is the softening pattern. So nothing much to show here, and let me take you to the end of this surgery, and that's the hard cataract gone, and of course the rest of it is routine. Let's see if there was another patient I thought I would like to show you here, because I think we are already out of time for the session. So this was a patient with a, I'm sorry, there's another one that I wanted to show you. Okay. So this was a smallish pupil, and there are maneuvers that you can do to give you a slightly better pupil size. Some people would like to use a B-hex ring. Some people would like to inject phenocane before they did the laser. If I'm getting a 4 millimeter excess, I will usually not do anything. So here we got a 4 millimeter excess, and then I've put a Malugins ring, and I've also done the softening. So the central part of the hardest part of the brown cataract is already cleaved. And although the periphery is not, but that's not the hardest part of the cataract, so it becomes easier to deal with it at this point. So you can see that even in a slightly smallish pupil, and here I'm using a Malugins ring, and this cataract is chopping much more easier because I already have the cracks in place in the central hardest part of the nucleus. Especially there will be some patients who have slightly compromised endothelium, and you are dealing with a very hard brown cataract, so you'll have two choices. Either you go with an SICS under viscoat cover, or you can do a femto-assisted if you want to minimize the endothelial damages, because you will be able to have much less effective echo time for those patients as well. So essentially, some of these patients will also have pseudoexfoliation. They will have capsular changes, and all those can be much better tackled. I think Dr. Ramamurthy was showing how to deal with rhexis in those fibrotic capsules. And then also for intumescent cataracts, I would have this as my first choice. The risk of the flag sign, of the Argentinian flag sign and runaway rhexis is much less in a closed chamber. And femtosecond laser is, even if it doesn't complete the rhexis, there will be a good imprint on the capsule at some points. All you'll need to do is just complete it. So here we've been able to complete it, and with that I think I would like to stop. And this is another coloboma with a hard brown cataract, but I'm sure many of these things have already been covered. So I would just like to summarize and say that for me, femtosecond laser has been a great tool for all the complex eyes. Post-RK, it's my procedure of choice. Posterior polars, intumescents, pseudo-exfoliation, very small eyes, very shallow chambers, hard brown cataracts. So I'm sure all that has been covered in this course today. Thank you.
So one question I have, what's your reduction in terms of percentage if you see in the CDE using the flax and not using the flax in like hard brown cataract?
So we've been kind of, okay, specifically for hard brown, see what's happened is that over time we've now made changes. The catalyst and most of the other lasers, they now, number of passes that they make, and the energy and the spot separation that we use, and also the central sparing, nomogram which came in. So I don't like to have very long procedures with the femtosecond laser now. Previously we used to do like 90 seconds to do the nucleus. Now my nucleus is done in 20, 30 seconds or something. So that transport delivers much less energy, it does the job very effectively. And I think the endothelium, I would again, as I said, procedure of choice, under viscoat cover, I would always do a femtosecond assisted cataract surgery for patients with compromised endothelium.
And what about using like a flower petal technique in cases like this in a femtosecond? Have you done that? Like once you've got the
flower
fragmentation?
petal happens on its own for me sometimes. I will have once I, kind of cleave the 6 quadrants or whatever, it separates out that endonucleus on its own, and you will just kind of, ease it out, and you have more space and a crater created, and then you do a lateral separation of the posterior plates.
As you mentioned, the hardness is actually right in the core only.
Right.
The periphery is not that hard in any way.
Absolutely, yes.
So we've seen all possible cases: posterior polar, hard cataract, brown cataract, rhexis, astigmatism. A question to the panel: if you have to get your cataract operated, would you even blink an eye? Would you do it with a femto? Yes or no? Everybody?
Definitely.
Yes. Gaurav, we need you on the stage. Any questions from the audience?
So for the small peoples, I tried the BX ring before starting the procedure. That is, gives a desired size of the rhexis. Need not worry about these myotic peoples. So only thing is inject the visco without bubbles. That is one thing. What is the lowest parameter of the ACA to prevent the damage of the endothelium?
Damage to the endothelium, anterior chamber depth doesn't matter. In fact, the lesser the depth, the better it is for you because your rhexis is definitely going to be better. In a dirty big white cataract or a big brown cataract where the chamber is terribly shallow, the endothelium is not good, there is an arcus, I think it doesn't matter one bit on the endothelium whatsoever.
But as this says, this definitely the grid pattern will reduce the phaco power. We compared direct thing with the grid. Grid definitely reduces the phaco power.
Yes, no question about it. In any and every case, the phaco power effectively goes down 50-60%. You saw his lovely, yeah, go ahead, Gaurav.
Okay, okay. You're next, we know that. You'll be first next time. We'll be behind you.
You want to minimize the laser time, so even the grid pattern can have compromises of the endothelium because of, too much energy being delivered into the eye. So it's a balance. You have to just strike the balance.
One second, take a picture. Yeah, thanks everybody. Friends, once again, congratulating Dr. Tityal on his victory yesterday. And a pleasure to have his first scientific session. We had planned it that way, to have the first session from the incoming president to be planned that way. So thanks so much, Dr. Tityal, for your time. Thank you, Gaurav. Thank you, Dr.
My pleasure.
Ramamurthy.
Thank you, Himanshu. Thank you.
We'll take one picture together.
Good morning.